Hello friends, today we are going to discuss about the preload responsiveness. The response to the fluid challenge is complicated by the cardiovascular physiology. Due to varying shape of the Frank-Starling curve could take depending on the ventricular systolic function, fluid challenge could lead to either significant or the negligible increase in the stroke volume and the cardiac output. If no attempts are made to predict the response of the cardiac output to volume expansion, fluid responsiveness occur in only half of the patient. So, should volume expansion fail to result in significant hemodynamic improvement, it inherently leads to the hemodilution and to increased cardiac filling pressure and eventually fluid overload. All these factors taken into lead one to view fluid therapy as any other medication which must be neither overdose nor underdose. Moreover, it argues for the careful prediction of effect of the fluid before they are administered when these effects are not shown. That is after the very initial phase of circulatory failure or if fluid losses are not obvious. So this is the Frank-Starling curve. So if the patient is the fluid responsive, if there is a significant response, then as you can see in this diagram. So the above two lines is showing the appropriate fluid response to the given fluid therapy. And the line below two lines, it's showing the poor ventricular response when we are administering the fluid. So there are some methods to measure this fluid responsiveness. The first one is pulse pressure variation and the stroke volume variation. The variations of the stroke volume and of surrogate that are induced by mechanical ventilation were the first method to be developed for dynamic assessment of the preload responsiveness. The rationale is that during positive pressure ventilation, insufflation decreases the preload of the right ventricle. When transmitted to the left ventricle, it induces the decrease in the preload of the left ventricle. If left ventricular stroke volume changes in response to the cyclic positive pressure ventilation, this indicates that both ventricles are preload dependent. Mechanical ventilation can be used as provocative test to challenge the slope of the Frank-Starling curve at the bedside. The amplitude of the arterial pulse pressure, that is the difference between systolic and diastolic pressure during mechanical ventilation, was the first used to estimate stroke volume. In 2000, the pulse pressure variation was shown to predict the response to the cardiac output to volume expansion, and this has been confirmed by the several studies. To date, the pulse pressure ventilation is the marker of the preload responsiveness that has accumulated the large amount of the evidence. Following invasive arterial pulse pressure, many of the surrogate of stroke volume has been investigated to assess stroke volume variation during mechanical ventilation. In recent years, the research has focused on less invasive and non-invasive techniques. This technique may be particularly useful when no arterial line in place, typically in the operating room. The ventilation-induced variation in the arterial pulse pressure estimated by volume clamp photoplethysmography, stroke volume measured by pulse counter analysis, the velocity time integral of the flow in left ventricular outflow tract at echocardiography, aortic blood flow by esophageal Doppler, and the amplitude of the plethysmographic signal has been established as preload responsiveness indicator. The reliability of the later index is likely lower in the ICU patient than in the operating room and in the case of vasopressor administration. So condition where pulse pressure and the stroke volume variation are less reliable. Spontaneous breathing, it can give false positive result. Cardiac arrhythmia, it will give false positive result. Then low PT and the low lung compliance will give false negative. Open chest will give false negative result. Increased intra-abdominal pressure will give false positive result. If the patient is tachypneic, the result will be false negative. In case of right heart failure, it will give the false positive result. Then variation in the vena cava diameter. The principle behind these indices is also based on the heart-lung interaction, but they do not operate in the same way as positive pressure ventilation. The changes in the intrathoracic pressure induced by the mechanical ventilation may induce some variation in the vena cava in the close proximity to the heart when central blood flow is low. The variation of the inferior vena cava measured by transthoracic echocardiography has been reported to detect preload responsiveness with the reasonable accuracy. The collapsibility of the superior vena cava has also been shown to reflect the fluid responsiveness. However, it requires transesophageal echocardiography. It has been recently reported that detection of preload responsiveness was better with the respiratory variation of superior vena cava diameter than with that of the inferior vena cava diameter. Compared to positive pressure ventilation and stroke volume variation, the inferior vena cava indices has been less well studied, and diagnostic threshold that were reported have varied from 12% to 40%. In 2014, the meta-analysis, which included 8 studies, the pooled sensitivity was only 76% and the pooled specificity was 86%. In more recent study in septic critically ill patient, the accuracy of ventilation induced changes in the inferior and superior vena cava diameter in predicting fluid responsiveness was found to be poor. It is important to take into account that variation of the vena cava diameter shares many of the same limitation as positive pressure ventilation. As anticipated, the accuracy of vena cava diameter changes to predict preload responsiveness in the lower is lower in spontaneously breathing patient. Accordingly, in healthy blood donor, it was not correlated with the cardiac output changes induced by the blood. The inferior vena cava variation was found to be poorer predictor of fluid responsiveness in emergency department where patients are usually spontaneously breathing, although contradictory findings have been reported. In recent study found that in patients with the spontaneous breathing only, respiratory variation of inferior vena cava diameter of very high amplitude indicates the fluid responsiveness. Although influence of tidal volume and the lung compliance on the variation of vena cava diameter have not been reported, it is likely that they limit the accuracy of vena cava diameter indices for assessing preload responsiveness and as with positive pressure ventilation and stroke volume ventilation. Uh, Nevertheless, in contrast to positive pressure variation and the stroke volume variation, vena cava diameter indices can be used in patients with cardiac arrhythmia. It has also been shown that distensibility index of right internal jugular vein was able to predict fluid responsiveness even though diagnostic accuracy was lower than reported for inferior vena cava. Now, passive leg raising, the internal preload challenge. Passive leg raising has been used for decades by rescuer as a first line measure in patients with dizziness and syncope. The PLR test is in fact the reversible preload challenge of around 300 ml of the blood that can be repeated as frequently as required without infusing drop of the blood fluid. It has advantage of being accurate in spontaneously breathing patient with cardiac arrhythmia, low tidal volume ventilation, and low lung compliance. The resistance to venous return does not change even in patients with intra-abdominal hypertension. In preload responders, the increase in the mean systemic pressure is accompanied by the increase in the venous gradient of venous return in venous return itself and thus in cardiac output. By contrast, in preload non-responders, the increase in the right atrial pressure that occurred simultaneously balanced the increase in the mean systemic pressure such that the pressure gradient of the venous return remains unchanged. The most important is that effect of the PLR must be assessed by direct measurement of cardiac output. It is important to recognize that changes in the arterial pressure do not allow the assessment of the PLR hemodynamic effects with reliability, and this has been confirmed by recent meta-analysis. When PLR-induced changes in the arterial pulse pressure are used, the specificity remains very good, but the sensitivity of the test is much poorer. The hemodynamic effect of the PLR reach their maximum within 1 minute, diminishing rapidly thereafter in some patients, especially in patients with severe sepsis and capillary leak. Intermittent measurement of cardiac output like thermodilution may thus be inappropriate. Nevertheless, this does not imply the PLR test necessary require invasive monitoring. Many studies have used non-invasively and minimally invasive technique to estimate PLR-induced changes in cardiac output. Both calibrated or uncalibrated pulse counter analysis technique are very convenient to use. Esophageal pressure with measurement of PLR effect on the aortic blood flow was first technique reported. Echocardiography with measurement of PLR induced changes in velocity time integral of left ventricular outflow tract has been used in many studies. Even the PLR induced changes in the peak velocity of carotid and femoral artery seem to be reliable indicator of the response of cardiac output to PLR. The totally non-invasive estimation of cardiac output by pulse counter analysis of arterial curve obtained from photoplethysmography is also suitable for PLR test, which may be particularly interesting out of the ICU and the operating room. An originally and totally non-invasive method to measure PLR-induced increase in end tidal carbon dioxide. This technique requires that patient has preferably stable mechanical ventilation, and in order to be sure that changes in the end tidal CO2 are only related to the changes in the cardiac output. A recent study showed that changes in the end tidal CO2 were able to detect changes in the cardiac output during PLR, but not during mini fluid challenge with 100 ml of the saline. It has been suggested that intra-abdominal hypertension invalidates the PLR test. Now, end expiratory occlusion test. In patient undergoing mechanical ventilation, each insufflation decreases the cardiac preload and tend to impede the venous return. Interrupting the mechanical ventilation for few seconds stop this cyclic impediment in venous return. So the cardiac preload transiently increases. If cardiac output increases in response to this end expiratory occlusion test, this indicates preload responsiveness of both ventricles. Of note, the duration of end expiratory occlusion must not be shorter than 15 seconds, likely because this lapse of time is required by preload change to transit through pulmonary circulation. Monet et al. Observed that whether cardiac output measured by pulse counter analysis increased by more than 5% during 15 seconds. End expiratory occlusion, a positive response to subsequent fluid insufflation, could be predicted with good sensitivity and specificity. The test has advantage of being very easy to perform. It simply requires stopping the ventilator as when measuring intrinsic positive end expiratory pressure and measuring the changes in the cardiac output. The end expiratory occlusion technique doesn't have technical constraint of the PLR. The main limitation of the test is that it cannot be used in patients who are not intubated and in patients who do not tolerate 15 seconds of respiratory hold. In published study, end expiratory occlusion test effect on cardiac output were assessed by pulse counter analysis. This technique has an advantage of being very precise. Indeed, for end expiratory occlusion test, the technique must be able to detect small change in cardiac output. Pulse counter analysis performed on the arterial pulse pressure curve obtained on the photoplethysmography has likely same capacity of assessing effect on the end expiratory occlusion test. This might not be the case for current version of bioreactance device, which average the cardiac output values on too long time for being able to detect changes occurring in the lapse of few seconds. The utility of this using echocardiography has recently been investigated. The increase in the velocity time integral of the left ventricular outflow tract during end expiratory occlusion was able to identify preload responsiveness with threshold of 4%. Interestingly, in this study, the effect of end inspiratory occlusion were also assessed. A decrease in the velocity time integral of more than 5% during end inspiratory hold was able to detect preload responsive patient. When both effects of end expiratory and end inspiratory hold were added, they identified the fluid responsiveness with sensitivity and specificity that were not superior or to either occlusion test taken separately, but with threshold of 15%. This cutoff value is more compatible with the precision of echocardiography. So this is the algorithm. So we need to see whether this whether is there acute circulatory failure, or there is low blood pressure or low cardiac output or signs of tissue hypoperfusion. If yes, is then we need to see if hypovolemia is obvious or not. So whether there is obvious fluid loss or whether it is just initial phase of septic shock. If the answer of this question is yes, then we need to perform the volume expansion. If the answer of this question is no, then we need to see whether there is a preload responsiveness is there or not. Are the following conditions are present? If the patient is spontaneously breathing or not, patient is in arrhythmia or not, or ARDS with low tidal volume or lung compliance is there or not. If the answer of this question is yes, then we need to perform passive leg raising test and expiratory occlusion test on the mini fluid challenge. If the answer of this question is no, and if the patient is on the mechanical ventilation, then to assess the preload responsiveness, we need to go for the pulse pressure variation or stroke volume variation, respiratory variation of IVC and SVC, passive leg raising test, and expiratory occlusion test, and mini fluid challenge. If patient is fluid responsive, consider volume expansion. If patient is not fluid responsive, then do not consider the volume expansion. Now, summary of the methods of predicting fluid responsiveness: pulse pressure and the stroke volume variation. The main limitation is it cannot be used in case of spontaneous breathing, cardiac arrhythmia, low tidal volume, and the lung compliance. Inferior vena cava variation. It cannot be used in case of spontaneous breathing, low tidal volume, and the lung compliance. Superior vena cava variation. The main limitation is requires to performing transesophageal Doppler. Cannot be used in spontaneous breathing, low tidal volume, and low lung compliance. Then passive leg raising. It requires the direct measurement of cardiac output. Then end expiratory occlusion test. It cannot be performed in non-intubated patient and cannot be used in patient who interrupt 15 seconds of respiratory hold. Then mini fluid challenge that is 100 ml requires the precise technique for measuring cardiac output. Then conventional fluid challenge of 500 ml requires the direct measurement of cardiac output and induces the fluid overload if repeated. Thank you guys.